again, pointing the intercondylar eminence or tibial spines. This 7, what's this pointing towards? What bone is it on? Tibia. Okay, so tibial, flat part, plateau. Yes. 6, okay, just pointing to basically the condyle. So obviously on the tibia, so it's going to be the medial condyle of the tibia. 8, patella. Okay. Arthrograms, occasionally what we used to do for joints, like in the shoulder, knees, sometimes the hips, is what they would do is they want to see if the space in there has been ruptured, okay? Either tear, ligament, bursa sac, been compromised. So what they would do is they, under guidance of fluoros, they put a needle in, inject some dye, and the dye leaks out of the space, then you've got a tear somewhere, okay? Because if you put it in this little capsule, it should remain in the capsule. If the capsule has been compromised, then it will leak out some space when you apply some extra liquid in there with some dye, basically, and a little bit of air, to see if it's in there or not. Occasionally, you might do an arthrogram every once in a while, but it's super easy. The radiologist tells you exactly what views to do, and they go in there, they do the pinpointing, they say fluoro on, put the fluoro on, they put a little needle in the spot they want to put it in, and then they're like, okay, it's fine. Put the needle in, inject the dye, and they say start taking some pictures. Okay, you should already be lined up over where it is. They may say, okay, turn on the other side, get a couple lateral views, and then bring it towards me. Do one after a minute, do one after 5 minutes, see if it's a time release, see if there's enough in there and it's starting to leak slowly or quickly, and then be able to tell if they have some type of rupture within the sac. This one here, lateral view, okay, rotated, okay, no angle problem, just rotation problem. These two vertical lines, not on the same plane. Okay. These two lines right here, pretty much on the same plane, so the tube angle's okay. Rotation-wise, it's rotated, okay? So what we need to do to fix this in relation to the heel, we go heel up or heel down? Where do we need to move this?
Heel up or heel down.
We need to move this forward or backwards?
Backwards.
We need to move this out more this way or more this way?
That
We
way.
move forward, okay? You look here, it should be slightly tucked underneath. This one is not superimposed at all, okay? So if you look at this, say, I need to get this bone going that way, okay? So if you go, how do I get that bone to move forward? Heel up or heel down? Heel down,
Oh, down.
okay? Heel down moves it forward, okay, because it's on the outside. Okay? You can think along those lines. You should be able to figure out how to do your corrections on this, okay? You're going to have to look at a few of these and then figure them out as we go along. Come to office hours, we're going to have a bunch of lateral knees that are all messed up, and we'll go through what it is until you figure out. So you should be able to go heel down, heel up. That one's fine. Heel down, and go right through all of them if you need to. We'll do some of that in class as well, but come to office hours, it's a lot easier to get. This one, also lateral, looks much better, okay? You can see the position of where the fibula is in relation to the tibia. See a little sesamoid bone on the back here, which you don't see on this one. Knee, sometimes you'll see the space in between that. But that's not really the key to tell whether it's a good lateral knee or not. Some people just have their kneecaps are just shaped a little differently. Some have a little tighter ligaments, pulled a little bit closer to the bone. So we wouldn't look at this and say, like this, rotation. We're not looking for rotation here, okay? We're looking for rotation here on the back part of the condyles. This one, equal amounts, tib, fib, femur, looks pretty good. Most problems, if you're going to default a little bit lower, okay? Because if they have traumatic injuries to the lower extremity, it's usually going to be on the tibia, okay? If it was on the femur, they wouldn't come in, they wouldn't be able to get out of their wheelchair and walk over to your table, okay? So if you're going to default on anything, make sure you get at least part of this. Because some people just get they just don't get enough of the tibia on there. If you don't get enough of the tibia on there, then they're going to ask for tibial series to make sure there's no osseous slatters and make sure there's no proximal fractures within the tibia or the fibular head. This one right here, speaking of fibular head, right in here, okay, very top one would be the fibular head of the right leg if it's hung correctly. Okay, I know it says left, but this isn't hung correctly. Problem with this film, distal part not on there. Okay, so pretty much a useless film. You need to have both joint spaces on there to make it a good tib fib. If you don't, then you're going to have to repeat it and you got to re-expose that entire leg. You could do just a small view of the ankle if you want to, but then you can't be sure if it's a perfect AP in relation to the first one you did. Okay, that's why we go caddy corner. That's why we don't use these small films like this. This one, pediatric. Okay, obviously small film. You can see the growth plates up in here. You see one on the fibula as well. There's down at the distal ends as well. When you have lung bones, you have growth plates at both ends, so they can grow in both directions. Fracture, kind of a transverse diagonal fracture, oblique fracture actually, right through the tibia here. And another one looks like down in here. Okay, so they may have pain up high, but we need to see the entire leg because of spiral fractures, twisting injuries, like a big old inflammation or swelling towards the knee, but then you don't see that there was a wrenching injury and then they have like a corresponding fracture maybe on the outside of the opposite bone there. This one just shows an AP and lateral tib fib. Okay, you see how it's going diagonally. This one's not perfectly centered well. Okay, this should be a little bit more over this way, and it should be going towards these points here. This one looks like it's almost there. This one clearly looks like it's towards the inside of the cassette. Okay, so make sure that the point of the cassette is right underneath the knee, right in the middle. Okay, if you do that, you should be able to fit most everyone on one 14x17 diagonal like this. Okay. This one just seems a little bit easier to get. Make sure you do not clip the malleoli on the inferior borders. Okay, if you clip the malleoli, because a lot of students look up here and they think, well, I got to get a big chunk of the knee on there. You really don't. You just need to get the top of the tibia, and the tibial spines stick up a little bit, so you got to get a tiny bit of the condyle. But we've got a lot more room up here than we do down here. Okay, so if you just go from here up, you'll have the positioning taken care of. Okay, just make sure the malleoli are on the inferior border of the films. The superior part will take care of itself as long as you're centered properly. Okay. Questions so far? Marker on the tibia, a little bit lower. Okay, see how it bulges out as we get a little bit more proximal. Okay, go where it's a little bit skinnier towards the bottom. Same thing on this film. Okay? On the laterals, just stay away from the condyles. Okay, so if you're going to be above the condyles where it's skinnier here, or below where it's a little bit skinnier, but not through the middle. If it's in the middle, then it's more likely that your condyles will superimpose your marker if you tuck it in too far. Or what happens a lot of times is the students won't tuck their marker in far enough, and then you just don't see a marker on the film. Okay, so go where the body part is a little bit thinner.